Hi, Zach. Welcome to the show.
Hi.
So, Zach, how did you get into medicine?
That's a great question. It's a long journey, not only the training, but the process of sort of getting there. I was really fortunate when I was in high school to have been called into the principal's office, but it wasn't for anything I did wrong. A pathologist had just moved to Pittsburgh, and he had kids who were in middle school, and he just enrolled them in the school. And at the same time, he had a number of postdoc researchers whose visas all expired, so they had to leave the country. And so he literally needed some hands in his lab to pipette and things like that. And so he came to the principal and said, "Hey, can you find me some kids that might be interested in doing some science projects? We'll pay them, we'll maybe get them on publications, that kind of thing." So I was one of the high school students that he chose to work in his lab, along with a couple of other kids, and I ended up going back for a few additional summers. Turns out, now knowing what I know about what I do, he was really important in the world of breast cancer research. I had no clue at the time. And so he and I worked together. He was one of the smartest people I've ever met. He really got me interested in oncology. And I am truly convinced that that experience with him is what sort of launched me in the direction that I've gone, helped get me into medical school probably, and landed me where I am today.
So, how old were you again?
I would have been like 16 or 17 when I was doing that.
And then you just loved it. So,
Yeah,
right.
yeah, I thought it was really cool. He explained to me sort of the rationale for why we were doing what we were doing. It was a research project on breast cancer resistance genes, which has accelerated in the last 15 years. That was sort of infancy research, and now we know a lot about it. And he explained to me all these different pathways for the different ways that breast cancer develops, how we treat them. And so I started to build this foundation of understanding, and it really just clicked with my brain, and how I sort of viewed my ability to contribute to the world.
Zach, tell us a little bit more about yourself. We now know that you are a doctor, and tell us a little bit what type of doctor you are and what you're doing at the moment.
Yeah, so I am a radiation oncologist. So there are sort of three branches to oncology. There's surgical oncology, medical oncology, and then radiation oncology. And they all serve complementary roles for different patients in different phases of cancer care. So radiation in particular is used when surgery is either not a good option or not feasible, to eliminate tumors to ideally reach a curative state. And sometimes it's used more for palliation of symptoms, when tumors are pushing on things, causing pain, causing bleeding, that sort of thing. In particular, I'm what is coming to be known as an interventional oncologist. And that is a subset of radiation oncologists who do procedures. By and large, radiation is delivered by x rays, so there's no physical contact. And that's what's done most of the world over. And some radiation oncologists will actually deliver radiation inside of tumors. So that might involve leaving a permanent radioactive implant in a different part of the body, a temporary radioactive implant, or something like that. And so, in particular, for prostate cancer, that's one of the main methods of treating a prostate cancer is delivering radiation directly into the prostate, when it hasn't been removed. And that's something that I do on a very frequent basis.
When it comes to prostate cancer, and since you're a specialist in the field, what do you wish people knew about prostate cancer?
Prostate cancer is very complicated. Most folks who walk into my office with a diagnosis have typically one option. It's either do the treatment that's recommended or don't do the treatment that's recommended, because there are no alternatives. With prostate cancer, it's a bit different. There are many different ways to reach the same endpoint of remission. Sometimes it's, again, with surgery. And then, even within the realm of radiation, there are a variety of options that are sometimes all suitable for an individual patient, and sometimes not all of them are a good fit for a variety of reasons. But it's a complicated disease, and the decision making process of how does one pursue treatment and which treatment to pursue is quite complicated. And we're learning more and more about the lack of understanding leading to sometimes regretting the decisions that are made, and the potential for overtreatment as well, meaning we're applying more therapy than we need to get to a state of remission, um, as the science evolves. And so we're getting better and better at these things as time moves forward, but it's an incremental process.
You talked about treatment. How do you decide what treatment to give a patient? When you just talked about some people are getting overtreated, that it's not really a one size fits all. When it comes to cancer, how do doctors determine what is the best treatment? And how does a patient know they're getting the right treatment for their type of cancer?
Yeah, absolutely. That's a multifaceted question. Certainly, patients are their own best advocates, but because prostate cancer care is really complicated, if you go hit up Dr. Google or use ChatGPT, you can get a variety of different answers that may or may not actually be applicable, to an individual's diagnosis. And so we come up with different methods of treatment for an individual based on how aggressive their prostate cancer is. And so that's predicated on a couple of things. Mostly how aggressive the cancer appears on biopsy and what their PSA is. And the PSA is a blood test, that is a surrogate for, not only how bad is someone's cancer, but also sometimes how big is their prostate. And so we use those to determine, should a patient have radiation? Should they have surgery? Should they have anti-testosterone therapy along with their treatments to try and improve the likelihood of, again, reaching that remission state? And historically, a very large contingent of men who were treated with radiation would have also been treated with anti-testosterone therapy. It helps improve the outcomes. It doesn't help everybody, though. That's part of the problem. And we have known that for a long time, but we lacked the tools to be able to differentiate the two. The men who needed the anti-testosterone therapy and the men who already stood to have a high likelihood of remission that didn't need it. And only in the last handful of years have we started to have tools available to us that help us make that distinction and better personalize the treatment options for these men.
So, right now, are you guys, with all this new scientific technology and AI, are we finding better ways to personalize people's treatment when it comes to prostate cancer?
We are, yeah. In particular, AI has found its home with a platform called Artera. Artera is an AI-based digital pathology platform that helps, again, quantify that magnitude of benefit of the anti-testosterone therapy along with radiation so that we can give more personalized recommendations to each patient that comes into our offices. It's a really neat platform, and it sort of takes what we know about prostate cancer and launches it to the next level. It takes a digital scan of a patient's biopsy. So the cells at a microscopic level are scanned at really high resolution, and then fed into this algorithm that compares that patient's pathology to the pathology of hundreds of other men who've gone through treatment inside of a clinical trial. So it's really rigidly controlled. And then it compares the outcome of that patient to all of the men who were in those trials to figure out, well, based on the digital pathology algorithm, does this person actually stand to benefit from anti-testosterone therapy or not? And so we use that now to help guide treatment recommendations.
So, do you use this when you're deciding if they want to do radiation and chemo as well?
So it has different applications in different settings.
Uh-huh.
For men with a more garden variety of prostate cancer that we refer to as intermediate risk prostate
Uh-huh.
cancer, the Artera test is really helpful for determining whether or not they need that anti-testosterone therapy. For men with more aggressive prostate cancers,
Mhm.
that we refer to as high risk or very high risk, they actually may be candidates for treatment intensification with a second drug. It's not chemotherapy per se, but it's sort of a compound anti-testosterone therapy. And again, we know that some men benefit from it, but not all men need it. And it's hard to tell the difference based on just what we see on paper and described by a pathologist. And so the Artera test has helped us, again, differentiate the men who actually may stand to benefit from it versus the men who are probably pretty well off without it.
Can you give me like a real life example where maybe this benefited a patient?
Yeah, absolutely. For the most part, find the benefit in this de-escalation of care. So most men with prostate cancer start their journey with a urologist, and
Mm.
then a decision is made as to whether or not the patient is a good candidate for surgery, if they want surgery or not, and then they're referred on to a radiation oncologist. And for a man with, again, that intermediate risk type of prostate cancer, they probably will come along and say, hey, my urologist said I need anti-testosterone therapy. What do you think? And that's where I tell them that historically, yes, that would have been the case. We would have given everyone like you anti-testosterone therapy for about a half of a year, because we know that across a whole population of men like you, it's going to help some. But now we have the availability of the Artera test that helps us really drill down and figure out, are you one of the few men who need it, or are you probably pretty well off without it? And so most of those men are pretty game to have the test run. It doesn't even require an additional biopsy, so there's no poking or prodding. The tissue, that high resolution pathology scan, comes from the tissue already obtained from their prostate biopsy previously, so they don't have to do anything additional. So in that regard, it's pretty high yield, and it's pretty low cost physically. Also financially, it doesn't cost that much. So that's a pretty big boon as well.
So maybe not that knowledgeable when it comes to the testosterone therapy and things like that. What are some of the side effects of somebody who does that type of therapy that you've been talking about and they
Yeah,
don't need it? What are some of those
yeah,
side effects that they could be experiencing for no reason at all? Because they didn't
yeah.
need to do
Um,
it.
Correct. Yeah. So no one really loves the anti-testosterone therapy. I joke with pretty much all of my patients that if they have to go on it, it throws them into menopause. So having your testosterone suddenly dropped by a medication leads to hot flashes, night sweats, fatigue, weight gain. It can induce metabolic syndrome that leads to type 2 diabetes, and mood irritability. So all of the things that a woman going through menopause may experience are absolutely things that men can experience while they're on the anti-testosterone therapy. It also has some downstream effects on cardiac health, so we know that it's not great for the heart as well. So if we can avoid all of those things, which are mostly quality of life, but some actually can lead to other medical issues, we should, especially in a setting where it's not going to help us cure the patient more often, and only increases the cost of their treatment and the inconveniences and the side effects.
So, what do you, as far as like for you and others, what led you or how did you find out about AI and all this great stuff AI is doing? I mean, how do doctors find these new ways to help when it comes to personalizing patient care?
There are so many different avenues to learn about new developments in medicine. Sometimes it can be overwhelming because if you open all of the floodgates, you will never get to the surface of it all. There are continuing medical education programs. There are conferences where new research is announced. There are obviously the journals where it's all published. There's word of mouth. And there are also guidelines that are published, that are available to everyone to look at, that have recommendations not only for the treatment of all of the different kinds of cancers we care for, and those patients, but also testing recommendations. And so there are so many different ways to keep current, and it can be tough, right? It's a
Yeah.
never-ending deluge of information, and so you have to find a way that works for you. I spend a little bit of time almost every day doing a little bit of reading, like 10 to 15 minutes, just to keep myself current on different topics. And I use a digest that's published 4 times a week pretty much to do it. So they do the great hard work of summarizing new and interesting information across a variety of topics, not just for prostate cancer, but for everything that we do. And I find that that's a really nice way to stay current. It doesn't take a ton of effort, but it allows me to stay on the cutting edge of what we do.
What would you like to see AI come in and start improving when it comes to prostate cancer?
There are a variety of different aspects of prostate cancer care that still are in the dark, more or less. Artera has helped us refine treatment recommendations for a small subset of men across the spectrum of prostate cancer. But there's still a larger group of men where the Artera test doesn't yet quite apply because it hasn't been built out and validated for them. But they are continuing to pursue different avenues to fill those voids so that we can best tailor our treatment recommendations for each and every man who comes into our clinic. I don't know that we will ever have completely personalized care in the sense that someone comes in and I say, you need 6 weeks of anti-testosterone therapy, and the next guy, he needs 38 weeks of anti-testosterone therapy. I don't know that we'll ever get quite there, but trying to at least drill down into more refined categories of treatment recommendations, I think we will see in the next 5 years or so.
So this is a question I have is what is the difference? And I think a lot of people wonder this, right? I hear someone says, oh, they're just doing radiation therapy. And then you
Mhm.
say people that said they're doing chemotherapy. What is
Mhm.
the difference of the two? And how do you know which one to do? How does the
Yeah.
doctor figure that out?
Yes. So the utilization for different kinds of treatments, whether it's radiation, chemotherapy, immunotherapy, which is a newer class of anti-cancer medicine that uses the body's own immune system to find and kill cancer cells, or a variety of other treatments that we have, are all based on clinical trials. So that is the gold standard to prove if something works, how well it works, what are the side effects, that kind of thing. So very smart people, people who are smarter than me, come up with questions and they say, here is this problem, i.e., a man with prostate cancer. The cure rates are pretty good, but not great. How do we improve upon that? And they look at the body of existing data and research and say, well, maybe if we throw anti testosterone therapy at them, we can improve the outcome. And so then they run a clinical trial wherein many men, hundreds to sometimes thousands of men, are randomized. So coin flip, they don't get to choose which treatment they get. Their doctor doesn't get to choose, and they get randomized to one of two or three or four sometimes different interventions. And then we follow them for many years to determine what is the outcome of the intervention. And so that's how we prove that new treatments work, like the anti-testosterone therapy, or in prostate cancer, chemotherapy for men with very aggressive or even metastatic prostate cancer, cancer that's spread to other parts of the body. And so we determine the roles of each of these treatments based on really tightly, rigorously designed clinical research and the results. And not every clinical trial comes out with a positive result. There are equally many, if not more, clinical trials that come back and say, that didn't work. We have to go back to the drawing board. And that's really important to know, right? Because just because you have a hammer doesn't mean everything is a nail. So you have to know which hammer to use and which nail to hit, how to hit it, that kind of thing. And that's what clinical trials really help us figure out.
And do you think the AI is going to come in and help with that?
I do. I think AI can help us in a lot of different ways. Pivoting away from prostate cancer for a second, perhaps. In let's say lung cancer, the garden variety of lung cancers, typically historically were treated with chemotherapy by itself, and there were only a couple of kinds of chemotherapy that worked. The prognosis was not great if the cancer had spread, and that was all we had. Fast forward a couple of decades, and now we have those immunotherapy medicines that have improved on remission rates and cure rates in patients with lung cancer pretty substantially. But there's still a void. And over the last 10 to 15 years, we've come to understand that lung cancers, especially among sort of all cancers, have a lot of genetic mutations that are potentially susceptible to different kinds of treatments. And so pharmaceutical companies have taken that knowledge and developed different drugs to target all of these mutations, then tested them in clinical trials to prove that they work. And now we have, for a patient with lung cancer, potentially, 5 to 10 different treatment options depending on what the mutation of the genetic mutation pattern of their cancer looks like. But every time you have one of these genetic mutations and a drug to go after it, it's not a sure bet that the drug is going to work, right? It may work
Yeah.
half of the time or 2/3 of the time. And so I think AI is going to help us refine those treatment recommendations and again say, okay, for this individual with these particular details and a cancer that looks like this and has these mutation patterns, what's the drug that's most likely to work? As opposed to saying, I've got a fistful of spaghetti and I'm going to throw it at the wall and see what sticks. So I think it's going to help us choose more effective treatments for each individual patient. And I think that will eventually apply kind of across the board for many different kinds of cancer as we move into the future.
As we kind of get ready to come to the close of our podcast here, I have a question I like to ask all the doctors. And it's, Zach, what do you like the best about being a doctor?
I love my patients. My patients are my life, right? They are why I do what I do. The high points are so incredible when you can tell someone that they're in remission, when you can tell them that all of the treatment that they've been through for the last sometimes many, many months, half a year, 9 months, have been effective. The sense of relief that you see in folks is really fulfilling. And being there as a team member with that person and building those relationships, I think is really gratifying. And the team around me, right? This is not a one-man show. I have a team of nurses, radiation therapists, someone who does all of the radiation planning for me, my physicist. Everyone is committed to these patients, and it's every day. It's a pleasure to show up and work with them all because everyone is there for the same reason, and we're all just there to help.
Everything you shared with me today is really fascinating because it excites me about how technology is improving the lives of those that have cancer. And prostate is it's the leading cancer for men, isn't it, Zach?
It is, yeah. About 12% of men will be diagnosed with prostate cancer in their lifetimes, which is not to say that everyone will need to be treated for their cancer. Some men don't need to be treated if it's felt to be non-aggressive, depending on how old they are and how many other medical issues they have. But it is the leading cancer diagnosis in men. And so parsing through that humongous population that are diagnosed with prostate cancer and figuring out how to best treat them if they need treatment is really important because it has downstream effects. There's no free lunch in cancer care. Everything has a side effect, even if it's mild. And so figuring out how to optimize that is really important. I think AI is really going to help.
Everything you shared today was super fascinating, and I appreciate you coming on the show so much. And I just want to tell you and everyone listening, thanks for listening. And until next time, stay curious.
Thanks so much for having me.